Hi, a very good morning, everybody. Thank you so much for spending your family Sundays with us and making this webinar a possibility. I am Dr. Aditi, and I am the chair of scientific committee of the upcoming conference in Kerala, Kochi this year by the name of World Implant Expo. The theme of this particular conference is to talk about converting implant failures to success stories. And in lines with the theme of this conference is today's webinar, where we talk about periimplantitis. Talking today about periimplantitis is our speaker of the day, Dr. Shankar Iyer, who's also the chairman of the upcoming conference. And Sir is going to enlighten us about all about identifying, preventing, and managing periimplantitis in a pristine implant cases. Sir needs no introduction. He's a very well-renowned clinician with almost 25 years of exclusive implant experience in practice as well as in implant education. After he found his roots in dentistry in India, he moved to the United States, where he completed his graduation and post-graduation in prosthodontics from NYU. He has held various posts, among which I think the most noteworthy has been the past president of American Academy of Implant Dentistry. He is currently the course director for AID Maxicourse Asia section and has been mentoring the AID candidates world over, including US, UAE, and in India. Sir has, Sir, through his educational and influence has been really carrying forward the legacy of his mentors, Dr. Leonard Linkau and Dr. Charles Weiss, very graciously. Without further ado, I now invite Sir to the platform, wherein Sir is going to give us insights into and his viewpoints about periimplantitis. Over to you, Sir.
Thank you, Aditi. Really appreciate the warm introduction. Good morning to all of you. It's just past midnight here where I am in the United States, and it's certainly a pleasure to be able to interact for this session with all of you. And we will entertain some questions after the conclusion of the webinar. Most of you have logged in because you're either facing implants, you're restoring implants, or having some kind of an issue with implants. Otherwise, you wouldn't be listening to me on a Sunday morning. And we've all been told that implants have a great amount of success and survival. And lo and behold, we see that it's not true. So to touch upon some of the aspects of the complications, I thought having this topic at this platform would be a good segue into the conference that we are going to be hosting very soon in Cochin. And we have assembled a galaxy of experts who will talk about different aspects of implant complications, including failures, periimplantitis, prosthetic complications, surgical complications, and so on. So let's look at the spectrum of periimplantitis. Okay, Albrechtsen really gave us a good overview of what really happens with an implant. After all, it is a foreign body, and you're introducing this titanium body into our bone, and you can start to have a litany of issues related to not just integration, but in terms of how it can impact upon the overall health of the surrounding tissues. So smoking, as you all know, is one of the etiological factors. You also have an immune reaction that could probably be precipitated with titanium and titanium particles. You can have what is called as fretting that could be setting forth a series of foreign body reaction. You also have overloading that could contribute towards crusted bone loss. Excess cement, which I'll be discussing about in great detail, is another reason why you are starting to see periimplantitis. And you have broken components, broken fixtures, and then you always have this imbalance of the osteoclastic resorption and the osteoblastic replacement through osteoporosis and so on. So when does it begin? We place an implant, we do it in a two-stage mode. And of course, even without placing a healing abutment, you can have a crusted bone loss. Well, why do we have this bone loss? Is it over torque? Is it the operator error? Did the patient do something wrong, chew on that side? Or is it related to particles being sheared off on the crest? We really don't know. We're only speculating that it could be as a result of over torque, or it could be a result of the poor manipulation, or it could be a manufacturing defect. And we can only hypothesize at this time as to why you're seeing crestal bone loss without loading. But a predominantly prevalent situation is the fact that when you do an implant in two-stage mode, we expect it to heal without any consequence. So why does the stage 2 and prosthesis play a major role in periimplantitis? Surgical failures will announce itself right away. You place an implant within 3 months, the patient is going to tell you there is a lot of pain, or the patient will come to you with the implant in their hands. So those are all attributable to surgical failures, either as a result of the operator error or a contaminated implant, or the patient's health history would be compromised. You have never seen a sleeper fail. At least there has not been a documented cases report of a sleeper failing. A sleeper is an implant that's never been used. So when we don't use an implant, doesn't fail, surgical failures are right away. So when does the implant start to see breakdown? The moment you put the abutment on, the clock starts ticking. The moment you load the implant, the clock starts ticking. We can call it as a micrograph issue or an overload. That debate can go on, but the truth of the matter is you are going to see the demise of the implant progressively. So when we look at the systematic review of some of the prosthetic risk factors for periimplantitis, there is again a whole slew of conditions that can cause a breakdown in the periimplant areas. Especially cement has been shown to be a major contributing factor. So there are about 6 of these factors I want to discuss over the period of the hour to be able to explore why do periimplantitis take a major role in terms of how it causes problems around implants. It starts with the abutment design, the shape of the design, the emergence profile, the way the permucosal device comes out through the soft tissue, all can contribute towards pressure on the surrounding tissue, which can in turn cause periimplantitis. It can start as mucositis, and here is an example of how you can get bone loss by poor contour. You can have an implant placed with a CAD/CAM milled abutment, and in about 4 to 5 years, you will start to see recession and bone loss around those abutments because of poorly designed contours. Everything is going to look amazingly great when you place the implant and when you restore it. But as the clock starts ticking, you're going to see a continuous recession. How do we control that? And today you're starting to see a lot of these CAD/CAM milled abutments where in the name of platform switching, you are now starting to see a direct flare from the implant, and that is going to crush the soft tissue, not giving it enough room to be able to provide for a papillary intervention or any kind of a soft tissue interface that is going to be conducive for peri-implant health. And then, of course, you're seeing a change in how these CAD/CAM implant abutments are being designed very poorly. You start to see a flare that should never exist. Well, the computer is not going to know what the condition of the soft tissue is because you're just scanning everything and sending it to the laboratory. So here's a technician who's looking at the exocad and just designs an abutment arbitrarily based upon the parameters that we provide. So this again is not the way to design these abutments. And we normally spend a lot of time trying to customize and contour these abutments and the emergence profile of the prosthesis so that they limit the amount of pressure being exerted on the soft tissues so that it does not contribute to a progressive breakdown. So again, when you see how these abutments are designed, this certainly does not call or for any sort of a definition for platform switching. For platform switching to really work, you need an offset of more than 0.5 millimeters, and you need to have a height or a variance right from that emergence point. So we need to be careful about how we design these abutments. So you manually create the emergence profile. You really need to study how these abutments are being planned right from the time of your impression taking. So if you have abutments that are going to have this kind of a flare, then of course you're going to see this kind of a bone loss that will inevitably set in because of the poor contours of the abutments. So it's not exclusively related to a peri-implant issue. These are prosthetic contributions to periimplantitis. You've also seen mucositis. In our effort to make the crown look natural with the emergence profile, we are using these fat healing abutments and fat body implants and fat titanium custom abutments, which is in fact going to create a lot of soft tissue problems. And with that pressure exerted by these CAD-CAM abutments, you're going to see an increasing number of periimplantitis, which is again going to be precipitated by mucositis. So the moment the design features come back from your laboratory, you are going to see these kinds of profiles that are being given to us, okay, by the lab. As you can see, this is a major flare. Now, how will the laboratory know how much of flare to place on those abutments? Unless and until we can give a soft tissue scan or literally carve a custom abutment that is going to be conducive to our soft tissue. So we need to be closely looking at the design features of these customized abutments so that it doesn't injure the soft tissue and provides for soft tissue health. So when we see these CAD/CAM abutments, I routinely go and instruct my technicians to kind of eliminate those kinds of flares and make it flat to allow room for passive insertion of a prosthesis and not put active pressure, especially when the implants have very thin facial plate. All right, so you can see how by contouring our abutments and our crowns, you can get an amazing soft tissue response. So if you're going to flare out your abutments, you can expect recession. But when we make those abutments concave, you can see the same abutment and crown have an amazing soft tissue profile just by altering the contours. So, and this is a 10-year follow-up of that abutment and crown, which has been, modified by just a chair side modification. So the next contributing factor could be the contours of crowns. Again, you can see these crowns which are trying to mimic the shape and sizes of the adjacent teeth, and that in turn is going to push the soft tissue. And this doesn't even have to be a cemented restoration. This can happen in a screw-retained restoration. In the absence of cement, if the contours are not going to be properly designed, you can see a tremendous amount of bone loss along the crest, and that only can keep progressing. So when you look at the crown design, you can see the negative architecture of these crowns. So take a moment, look at the crown design. These crowns have to go up like this from your abutment and not have a ridge lap. So ridge laps should be avoided. So you have to really look at the anatomy of a tooth as it emerges from the platform, so you do not have these ridge laps. So these ridge laps happen around the soft tissue. It is going to create a lip, which in turn is going to cause a lot of bone loss. This may not affect the contour of the soft tissue. The soft tissue is still intact, but it's all diseased. It's just like how you can have a 10-millimeter pocket on a tooth and still have a papilla. So it is analogous to how you are seeing periodontitis on a natural tooth with deep pockets. And this is periimplantitis, deep pockets. Turner's principle of having that 5-millimeter rule is in theory okay, but then you have a disease condition like this, you can pretty much have a papilla doesn't mean it's healthy. Look at this. You have a mesial and distal papilla in a diseased tissue. So from the contact point to the bone, you have more than 7-8 millimeters. Yet you still see a papilla. Doesn't mean it's going to be healthy. And that's not what we want to be promoting. You want to promote a nice soft tissue profile, which is disease-free. So abnormal contours need to be adjusted. So from here, we take a green stone and you tell the laboratory, I want an emergence profile like this. I don't want it to look like the adjacent tooth. So when you contour this, you can see the difference in how these crowns are contoured. And this is going to be supporting the tissue much better than what a ridge lap crown looks like. So basically, we need to redo this. So how am I going to fix the bone loss that has already taken place? Surgical intervention certainly would be the way to go, because you really would have no access to the site for debridement. So I'm raising a full thickness flap, and then you can see all of the threads being exposed. Well, again, there are a lot of protocols regarding management of an exposed implant. There are techniques of implantoplasty as outlined by Hamle Wang. You can also have laser ablation. You can have titanium brush. You can have all kinds of magic liquids that you can put on this. But we really don't have any prospective randomized study that shows consistently that that technique works. But what does work are these saucer-shaped defects. If you have a saucer-shaped defects, you can certainly manage this very easily. If you don't have a saucer-shaped defect and you just have the bone loss at a horizontal level, that's going to be much harder to build up the bone. So what you see here is a 3-wall defect. You can certainly debride, decontaminate. You could use citric acid. You could use tetracycline placed in sorry. You could use glycine, chloramine T. These are all some of the chemical treatments of the surface of the implant, including laser ablation. And my go-to would generally be synthetics, because we don't want to put anything organic on the surface of the implant, because the organic content could set forth some kind of a nidus for superadded infection. So a anorganic bone graft would be ideal, because it's purely acting as a space filler and preventing epithelial invagination over the implant surface. So typically we would like to make our flaps from the lingual area, try to increase the keratinized tissue, and that is one simple way of handling some of the recession defects. The next, of course, is going to be emergence. The emergence from the sulcus. This is another contributing factor for periimplantitis. You have a ridge lap, which is inexcusable. Either the implant was not placed deep enough, or the laboratory didn't know how to really fabricate the crown. So we as clinicians, we really need to figure out how a tooth should look like as it emerges from the gingiva, so that we can have a proper contour and emergence profile that is going to keep the soft tissues healthy. So whenever you see blanching as you're placing the crown, whether it is screw retained or cement retained, blanching in general is not a good thing. If it's not a good thing for natural teeth, it's certainly not a good thing for implants. So how do we manage this? Again, use your cup-shaped disc. You want to create a negative contour. You always want to cut back. And then as you're placing it in, you will see that the blanching will start to disappear. So these things will contribute a lot. So every time a crown comes back from the laboratory, whether it's for a natural tooth, for an implant crown, look at the margins, because your scan body or your computer is not going to be able to differentiate the marginal gingiva from the tissue biotype. So it is your responsibility to draw a line from the gingival margin to be able to know where the offset is going to be and how you're going to be carving it to make it concave so that the pressure is minimized. And then you can see how the stability of the soft tissue is an immediate placement, and we would like to see an emergence profile. So this is just a flavor of what's coming, and we have some luminaries around the world who are going to be participating in our World Conference. The World Implant Expo is a non-commercial, and it is just being provided for a scientific platform by Smile USA as well as Roseman University. We are also thankful to DentistChannel.Online, and you can see the quality of the speakers, and this is what they're going to be talking about. The problems that keep you at night is what we want to discuss. We want to empower you with solutions that you can take home and benefit from. Implants are not free from complications. So if you really want to know how to get into the science of managing failures and complications, this is your chance in one podium, because everybody is very happy to share the successes. Very few will actually share the failures. And these are our experts who are coming to the conference to share what they have overcome in their practices. So the next aspect is cement. Cement has been hashed to death, a million times. Everybody's blaming the issue of periimplantitis with cement. Usually, the cement retained restorations are retained by resin cements, and resin cements are the main reasons why you have periimplantitis, the extrusion of resin cements. All right. So you could see that this patient presented tooth number 1-1. It looks healthy because a visual depiction of periimplantitis is deceiving. You can't really look at the tissue and say there is going to be periimplantitis, but when you press on the gingiva, you can start to see some exudate come through. So which means you probably should be probing these sites. And when you probe these sites, you will see tremendous pocket depths. This is a whole layer of cement. Okay, the dentist cemented this crown with resin cement, and there is really no epithelial seal or attachment. So it's going to extrude right into the level of the surface of the implant. And then if I have to raise the flap to see what's going on, you can see the cement excess right on the implant. So when you place your subgingival margin and you want to use a resin cement, there's no way we will be able to clean this off. And if you're using a platform switched abutment, it's almost impossible to clean it under the abutment. So be careful about what design of abutments you use, what kinds of cements we are going to be using, and especially when it comes to all ceramic restoration, you have to be doubly careful in using resin cements. Now, where does it stop? It keeps progressing. All right. If you're going to fill this entire crown with cement, that cement excess has to go somewhere. It's not going to come towards the sulcus. The path of least resistance is apical. So it's going to extrude more apically, and that is only going to cause loss of the entire facial bone. And there is no way we will be able to treat this except to remove this implant, debride it, and make sure you have a clean socket. All right. And then again, when you're probing these sockets, right, the pockets, once upon a time probably was not probing, lack of attachment, and you will see why you're seeing a problem. So when you have a negative architecture in your abutment and the cement goes beyond, it's going to be very difficult to keep that area clean. So you will start to see mucositis, and then when you open up a flap, you're going to see a complete loss of the facial plate, circumferentially actually, right? So this is one way of minimally invasive management. Would be with the use of erbium YAG, which is specifically meant for detoxifying the surface of titanium. All right, so it's a preset which you would use with a erbium YAG laser. And then again, my go-to would be a synthetic graft over it. Again, you could see the cement-induced periimplantitis over and over again. I cannot overemphasize the use of, kinder cements like, Tembond, zinc oxide, eugenol, those kind of cements are better. But when you start to see these resin cements, it is going to start to create a major breakdown. So the saving grace is the polish collar. So polished collars are resistant to periimplantitis. So there is room for having that machine collar as your guard whenever you're trying to get an implant to have a good soft tissue profile. You don't want these roughened surfaces exposed to the soft tissue. All right. And here again, as you're going to see how we're going to take this off. And the only way to fix that would be to do some graft and using some mesh, sticky bone, wait for it to heal. And then you can see how you're getting some bone growth over. All right, at stage 2, we get our implant placed. All right. And then, of course, the final restoration. The materials aspect of it, what kind of materials are we using? You want to use a very good biocompatible material, not something that will disintegrate or abrade. So here again, this implant is exposed to the soft tissue, so the surface matters a lot. So ask your manufacturer, what are the RA values of the surface texture? Is it 1.6? Is it 2? Is it 4? Is it 8? Because the RA value, while it has a good connotation for integration, it can also be a deterrent for progressive bone loss, right? We want to make sure that we don't use something that is going to be extremely rough, that it causes progressive bone loss when there is initial bone loss. All right. And there again, we are going to sort of do some laser ablation. Again, I'm not promoting lasers or any kind of technique, right? So whatever technique you're going to use it predictably so that you can leave behind a clean surface. You can use slurry, you can use titanium brush, but don't use something that is going to further contaminate the implant, right? Implantoplasty seems to be an alternative, but then if you can have a defect that can be covered with bone, use that. When the implant is freestanding with no osseous structure to support it, then of course implantoplasty would be a way to go. All right. So once it's debrided, as long as you have 270 degrees of support for the surface, that's good enough to be able to receive the graft, and you can get an additional 4 to 5 years out of the procedure. And then when you close this up, you can have a fairly good resolution, and that's going to be stable for several years. What about, cases of full arch, all on fours, graftless solutions? They also are subject to progressive periimplantitis. Angled implants are not easy to manage. The moment you're going to see this kind of breakdown, you can have an entire surface exposed. Okay, it could be as a result of smoking, poor tissue contour. It could be overload. Okay, so these all need to be completely debrided. All right. Sometimes, if you want the bone growth to take place, you may want to remove the multi-unit abutment, place the cover screw, let the prosthesis be on all on 3, let the implant heal, unload it. All right. And then you can see how we are managing this site. All right. So this is where the implant is starting to lose bone around this area. So make a large flap. All right. And then, of course, we would be debriding and decontaminating the surface. You can also use a titanium brush as an adjunct. The advantage of the laser is that you can use this 360 degrees. There are laser tips that can go at 45-degree angle. I'm also using the osseous, the coagulum from the ND YAG, and then a synthetic graft, a non-ceramic HA, along with the PRF, and then we would suture this up. Occlusion also has some kind of a role to play when it comes to periimplantitis. It is acting as a cofactor, all right, because After the micro gap, there's no other reason why you should get progressive bone loss. So Carl Mesh's theory is about overload. So there are basically two camps. You got Lindy and Dennis Tarnow on one end that, who say that bone loss is due to periimplantitis reasons. All right. That is the so-called microgap. And then, of course, you have the second concept of the overload, which was made popular by Marthabitis and Isidore, AP spread, the amount of torque that is going to be inflicted on the distal abutments and the length of the cantilevers and so on. So this is the dilemma. This is by Bergelund, says plaque accumulation around implant surfaces can initiate periimplantitis. So you really need a kind of a substrate to be able to promote periimplantitis. Okay. Then when you have an occlusal overload, can result in marginal bone loss without inflammation. This is Miata and Isidore saying you can get bone loss in the absence of periimplantitis. So that's pure overload. And then Miata also goes to say when both are present, the periimplantitis inflammation can be aggravated and it can also increase the rate of bone loss. It's almost like a cofactor. So when there is bacteria and plaque associated with the overload, you can see a progression that is going to be irreversible. So then we're all priding ourselves in creating a papilla. Oh, let's bring a papilla between two implants. And then there's debate. Maybe there should be zero bone loss concept. And I used to really spend a lot of time creating this papillae for all of my FP1s. But what is that papilla? There's nothing healthy about a papilla. A papilla is nothing more than an hyperplastic tissue. There's really no purpose for this, right? Health-wise. For a natural tooth, the papilla occupies the embrasure area, prevents food impaction, and so on. But it's an implant, and you're sinking the implant 4 or 5 millimeters away from here, and I use a perineal probe, it's basically a pocket. So the deeper and longer the papilla is, the greater pocketing we are going to get. So this may come back to haunt us down the road. So, kind of puts me in a quandary to see while I am spending a lot of time developing a papilla, is that papilla really a healthy tissue, or am I setting myself up for failures down the road? So this is a case of mine, which I, created this with a provisional, right? This is a full arch case with an FP1 prosthesis. I spent a lot of time creating this papillae. Look at this deep papilla, right? And in 2017, it's 10 years post-op. Okay, you can see the bone levels are not too bad. And I had papillae on every site. All right. Then about 12 years later, okay, I'm probing. These are all cementable prostheses with TEM bonds, so I don't have any cemented periimplantitis because it didn't happen 10 years. Now I have a pocket. So what really was a healthy tissue now became a pocket. And now when I get bone loss, the papillae still stays. You see that? The papillae still stays. The bone loss can keep happening. So it's not true that with the bone loss, the papillae will shrink. This is now a pathology. So if I have to manage these, I will have to raise a flap, curette the entire area. I'm using a titanium brush to decontaminate the surface. All right, it'll take a while to clean and make sure that this is nice and shiny. You can take a diamond, you can want to take away the micro threads. So now I'm being very careful in choosing my implant designs. You want to choose an implant design that doesn't have aggressive threads, which are difficult to clean. I don't want threads going all the way to the top of the platform. So I'm a little more conservative in my implant choices to minimize periimplantitis. Because all this while, when I was using Panama implants, and I was using some of the older designs of tapered screw vent, or some of these polished collars with the external hex, we didn't see this much of an incidence of periodontitis or periimplantitis. Now, with the use of toughened surfaces going all the way to the top, not realizing what kind of coatings are there, what kind of surface mat treatments are there, I'm finding it increasingly difficult to maintain these surfaces. So I'm using, again, a non-ceramic HA with a PRF, which will then result in a loss of the papillae for sure. And then at least I have bone levels that are now maintainable, and the pocketing has significantly diminished. Is this real re-osseointegration? I don't think so. This is purely a radiographic fill. So I don't think an implant that has already been contaminated, you can purify to a point you can get re-osseointegration. Re-osseointegration definitely is not going to happen on a surface that's already been denuded. So do we splint or do we leave it freestanding? Some of the ill effects of splinting can also lead to bone loss. So when there are 3 implants splinted together, the middle implant apparently seems to have greater bone loss. So this is a work done by Rotney and also Pillier. This is the group from Toronto, Douglas DePorter. So their implants were all sintered implants. So this is their study. The data suggested that long implants and or splinting can result in greater crestal bone loss. Longer implants and splinted implants appear to favor greater crestal loss in this investigation. So basically, they're advocating short implants, leave them freestanding. These conclusions are, of course, specific to the implants used and may not be relevant to other types. So now when you're putting 3 implants together in a splint, the chances are the middle implant may have a propensity to undergo some kind of a bone loss. So this is one of the conclusions from that study, where it says screw retained superstructure and crown margins located. It should be, of course, equicrestal, right? You don't want to place the crown margin subcrestal, because when you have it intrasulcular, it's easier to remove the cement excess. All right. This is a patient who had placed implants about 13, 14 years ago. You can see that this is a design of a tapered screw vent implant, which again has a machine surface, right? I placed this as an immediate placement, okay, almost 15, 16 years ago. So you can see the facial plate is intact. Now, the hypothesis here is that you all know about facial growth, right? When the facial growth continues to take place, this is another hypothesis by Daftari and Oded Bahat. So with the facial growth, we are starting to see the implants getting exposed. So we're trying to figure out why this is so. The loss of facial plate could be as a side effect, because as the face grows downward and forward, the implants don't move, but then the resorption of the facial plate continues. So here is what is going on. The same site that you see here, 10 years later, you can see the facial resorption taking place. All right. You can see how the facial plate will start to cave in. And now I'm starting to see some pocketing. The patient says something doesn't feel right. I'm also starting to see some grayish hue. So pocketing is also 8 to 10 millimeters. So when you open up the flap, you can see the machine collar. That's what is resistant to periimplantitis. That is why you don't see any inflammation or redness. So when you reflect the flap, you can see the entire facial of the implant exposed. Totally asymptomatic, all right? Of course, the pocketing is there. So how do we manage this? We probably will have to just use some synthetic grafts just to have a cosmetic seal or a cover. So again, after debridement, I'm using synthetic calcium sulfate mixed with nanogen, which is going to be layered over this exposed surface. All right. And then a membrane is placed right over, and we shall close this up. Of course, the blood supply is going to be compromised on the crestal area. So the immediate post-op is going to be quite ominous. You can see, I'm seeing the surface of the polish collar. What do we do? Okay, not to panic. If you have done the protocol properly, and if the crestal portion of the implant is machined, you have nothing to worry. I told you the surface of a polish collar is resistant to periimplantitis. And then all I'm doing is changing the abutment and replacing it with a regular crown. This is 5-year post-treatment. Another reason for periimplantitis would be the shape of the prosthesis. A hybrid prosthesis is not a screw-retained denture. I just saw a case today that was sent to me, which looked like as if it was a horseshoe that was screwed in. It's totally wrong. You cannot have a moat. You have to have convex surface where the tissues are contacting the prosthesis. This is now a concave surface. All right. So the preferred design for an FP3, if you're using a multi-unit abutment, is always convex. All right. So use multi-unit abutments. Try not to use fixture level prosthesis because it puts it too deep, and you should not have any kind of a ridge lamp. So the surface of your prosthesis should always be convex, and see how it actually helps in cleansing. Look at this design and look at this design here that you see, wherein you have a concavity, right? Your prosthesis needs to be convex. So when we place this, it actually goes and becomes self-cleansing. So what do we do in our practice? We remove the prosthesis every 6 months. We remove the prosthesis. My hygienist does a thorough job cleaning the prosthesis. So this is what we do. All right, but you're going to be unscrewing the prosthesis. All of the prosthetic screws are tightened at 20 newtons. We will remove the entire screw, check for passivity, because I'm not doing this just for cleaning. This is a biomechanical design. So all of our hygienists are trained to remove the prosthesis, check for the intactness. You don't know if the cylinders have come loose, if the prosthetic screws are broken, or if some kind of a misfit. You don't want to be taking a chance. So this is what's done. And then you'll see how the maxillary and mandibular prosthesis, full arch restoration, which is designed just to fit the teeth surface. It's not bulky. We will remove this. And then what we do is go and probe around each of these multi-unit abutments. Probing again is very controversial, and you saw you can miss stuff. If you don't probe and if you just visually see it, you can miss a lot of pocketing. So bleeding on probing, while it's not an indicator, probing depths is an indicator. And we picked up so many cases of periimplantitis just by probing. We let the patient know it needs intervention, and that's going to maintain your prosthesis. And look at the health of these abutments. So I'll show you the close-up. This is what my hygienist will do. They will actually probe around each of these abutments to make sure that they are not bleeding. They're not probing beyond 3 millimeters, because even though you probe, you may be hitting the bone. All right, but at least you can pick up infrabony defects very easily. So this is what our hygienists are trained to do. And we charge a fee for this visit. All right. And then what do? They will take the prosthesis, they will brush this and place this in a sealed bag with chlorhexidine. All right. And then that is placed into a ultrasonic solution. all right, and that vibrates and takes away all the plaque. And then we would take the actual prosthesis, make sure there's a proper mesh, you don't lose any screws, and these are all scrubbed. And once it's scrubbed properly, we want to make sure that the cylinders are all intact and there are no debris, there's no change in the color. And this is what we do for every prosthesis. So I have two hygienists working full time, and this is all that they do every 6 months for our patients. And then we take our chlorhexidine, we would be cleansing all of the abutments. We'll take the screw, again, clean all the screws. You don't have to change the screw. You're using the same screw, all right? And then after you vibrate and remove all the plaque, we would take the prophy cup and polish all of these abutments, all right? And that's mixed with chlorhexidine, all right? And then you can see how each of those abutments are actually cleaned. So the abutments need to be squeaky clean, all right? And that also gives us an idea of how intact all of these processes. So we have 15, 20-year follow-ups with these cases that we've been maintaining. And that's one way to minimize your periimplantitis. This is chlorhexidine gel and prophy paste. So after it's all completed, all the screws are loaded on the prosthesis. All right, we would be placing these screws right back into the prosthesis. And you will see how our associates will put the prosthesis back in. So the hygienists are not allowed to remove. The unscrewing part is all done by our associates, and the hygienist will take over from there on. All right, so again, after we hand tighten it, we would use our torque driver and we torque it at 20 newtons. So consistently, we have the same torque for every prosthetic screw. So there it is. It's torqued at 20, and then the access hole is all covered with Teflon, and we use pink cabot because pink cabot is stronger than your white cabot. It becomes rigid, almost like IRM. So that's the Teflon going into the access holes. And it's easy for our hygienist to find those access holes and remove the Teflon and be ready for maintenance. So maintenance and periimplantitis, they go hand in hand. So if you're taking on an implant case, you better tell the patient that they're in for trouble, all right? Do not promise the world. Just like teeth need constant maintenance, your implants will also need the same, if not even more, level of care in terms of follow-up. Okay, so again, I take this opportunity to invite all of you. This is just one of several presentations that will be given. We'll be talking about how to remove broken screws. We'll be talking about nerve injuries. We'll be talking about fractured implants and how to take them out, how to manage zygomatic failures, how to manage prosthetic failures, aesthetic dilemma, how to manage complications with the partial extraction therapy, how do you manage complications with sinus surgeries. So this is really a world-class meeting, and I, would like to meet you in person and welcome you to this scientific endeavor that we have embarked upon. And I want to thank DentistChannel.Online for setting this up, and to Dr. Aditi Nanda, the chair of the conference, for moderating the session. Thank you.
Thank you so much, Dr. Iyer. We are now open for our question and answer.
Any questions that are there?
So we did have a couple of queries in our chat box, sir.
Sorry, 1 second. Let me increase the volume. Sorry.
Yeah, so we did have a few queries from our participants. Death by cements is something which we really have to take care of when we are talking about a cementable prosthesis. So what would be your take on selecting the cements for a cement retained implant restoration?
Okay. In the order of biocompatibility, as described by Dr. Chandur Wadhwani, he's the world expert, and I've co-authored a paper with him. The kindest cement is a zinc oxide based cement. So it could be Tembon, any Tempzone. These are all eugenol based cements. And that again is the kindest, followed by, we would say, um, Dical is another good cement. It's calcium hydroxide based. Once you get to polycarboxylate and the resin cements, you're in for trouble. So what's a good way to cement? You would have a replica. You would use blue mousse or have a replica of the abutment that is going to be inserted into the crown. We would put the cement into the crown and place this blue mousse silicone index into the crown. So all of the excess will be out. Then you would go and cement the restoration. So this way you are minimizing the cement extrusion. The next way to manage this would be what's called as a reverse margin. Instead of the margin going down, you create the margin reverse. So when you put the crown in, the hydraulic forces will bring the cement occlusally rather than displace it gingivally.
And what special insights would you share about resin cements? I mean, do you recommend using a resin cement regularly? Because of late, that's what is
There's a lot
occurring.
of this. Yeah. So the first the only reason why you're using cementable restoration is the angulation, right? Once the angulation in the aesthetic zone is going to be proclined 25, 30 degrees, then you're going to use a custom abutment and a cementable crown. Up to 20 degrees, you can safely use angulated screw access channel. So we use an ASC pretty much routinely, and that minimizes the use of cement. But if you must use your cementation protocol, then my preference would be to use a custom titanium abutment and a PFM crown. So if I use a custom titanium abutment, I can put grooves and boxes, and I can cement these crowns with Tempon, and that Tempon will never come off. A Tempon is there to pretty much stay.
So that's basically like the screw-mentable that you're recommending.
Right, exactly.
And what's your take on the selection of the bone graft, and if there is any risk of recurrence when we are treating our periimplantitis cases?
Right. Again, if you are going to use a graft material, I would not use an organic bone graft because you can set a nidus for superadded infection because the site is already infected. So my go-to would be a bovine graft material or a synthetic graft material, which acts as a scaffold and is biocompatible. At the same time, it will prevent any epithelial downgrowth on the surface of the implant. So basically acts as a barrier and stays put, may not necessarily contribute to integration.
It's basically for contouring and preventing the epithelium.
That is correct.
And how about, you talked about splinting of 3 implants. How about 2 adjacent implants? Do you recommend that, because this is commonly seen in the this thing? So
Right.
would you recommend a
So,
splinting or going ahead?
right. My topics on splinting is, depends on the connection. So if you're going to be using an implant that is going to be made of a grade 4 titanium, then splinting probably may be essential, because if you're going to leave the implants freestanding, it'll last for about 5 years, but then there's bone loss. You don't have that coverage on the circumference of the implant. So as the bone loss takes place, the wall of the implant becomes thin and the stresses will cause the fracture. So in those cases, splinting would be beneficial in terms of just distributing the load.
For your prosthetic screws, how frequently should these screws be replaced?
Very good question, and actually a tough question. There's really no hard and fast rule. We really don't have any major scientific publication that says you need to replace it. In fact, many of the publications have said not to replace the screw. If a screw loosening takes place, use the same screw. The problem is one of preload. So if you have embedment relaxation, go back to the screw and retorque it. So if you're going to be using these screws repeatedly, taking in and out, and if you find that the torque is not being achieved on that screw, then I would change it. So for an all-on-4, we do have a protocol in place. As you saw, we take them out every 6 months, not because of cleaning is a factor, because you're dealing with a biomechanical variable that you have no control over. You have cantilevers, you have forces acting on it, needs to be passively fitting. So it's more of a check that we remove this. And as a side benefit, we are also able to clean the abutments. So in my practice, we don't routinely change the screw. We wait for about 3 years. We look for any surface defects. It's basically if your driver doesn't catch that screw and you're starting to strip, then it's time to change it.
And also the protocol stays same for your regular screw retained or screw mentables, because with now screw mentables becoming very common. So I'm not talking about a full mount, I'm talking about your bridges. And
Like I
how
said,
about your single
yeah,
crowns? What's your go-to maintenance
bridges,
protocol?
yeah, good question. Again, we don't remove bridges and single crowns. And FP1 prosthesis stays forever unless there is a detectable problem. It's only for an FP3 we remove.
Thank you so much, Dr. Iyer. These questions and these pearls of wisdom that you shared with us are really going to help us to take our implant practice a long way. And I hope that most of our participants have taken a lot of these insights and they're going to implement it in their practice in days to come. And we really hope as a team we can see a lot of these your faces at the conference, where a lot more speakers are going to be sharing their insights, their perspectives, and share with us the pragmatic tips for making our implant practice a lot more successful than what we are having as of now. Any parting words, Dr. Iyer?
Yeah, so I was just browsing through some of the curious questions. I have Jacob who's asking about predictable method of positioning anterior implants to make them screw retain. That's exactly what I spoke about in terms of the angulated screw access channel. And of course, when it comes to a cementable restoration, which I'll probably speak at the conference, we're able to, pop them off predictably with Tem bond. So somebody asked, Dr. Jane asked about an RA value. RA value is the amplitude of the surface. So if you ran a profilometer over the surface of the implant, you'll have the surface roughness. So an RA value of 8 or higher is usually seen with a coated implant. A conducive surface is something that is less than 2 microns would be the RA value. All right. So occlusal scheme, Dr. Nikhil asks for an all-on-4 is mutually protected occlusal scheme. So we want to have canine guidance. We don't want bilateral balance and not even group function. So Jacob again asks if the threads are exposed, should we use it the polishing burr? Again, if you can do implantoplasty, again, depends upon the type of implant. If it's an implant that is going to be aggressively threaded, you probably will have to do some implantoplasty. If it's a subtle thread, you can probably just polish off the roughened surface. Okay. So okay, there are a few more questions if I can skim through them. Dr. Thorat says, can we keep access home on occlusal to minimize excess cement and sulcus? Also single count retrievable cases. Access hole on the occlusal. Okay, so it's almost like a venting space. So if you use a venting space, you might as well do it like a screwmentation. So you have the cement done outside, and that is what you mentioned as a screwmentable type of restoration. All right. So I think we should be concluding this. I don't know if any other questions.
I think
If
that
you
kind
have
of
any.
completes a chat box. Yeah.
Good.
Yeah.
So stay tuned for more to come. I will probably run this series in about a couple of weeks. We'll talk about surgical failures. And again, I'll talk about prosthetic failures just to set the tone so that everybody's aware of what's happening. So when you do come for the conference, we have an idea of what you're looking at. All right. So send us a email, check me on Instagram. I'll be constantly posting updates and looking forward to meeting you in person. Right. Thank you.
Thank you
Thank you,
so
Dr.
much,
Nathan.
sir. Thank you so much, sir. Thank you, everybody, for joining us, and wish you a very happy Sunday ahead and a very good night to you, sir.